Hello, I'm Mike Lemons with DxTx Pain and Spine, and today's topic that we're going to address has to do with aggressive behavior with patients and de-escalation techniques and how those are handled. With me today, my cohort who's been on all these podcasts with me, Dr. Jesse Hatchis from Anesthesia Pain Care Consultants in Tamarack, Florida. And we have a special guest today. We have Darla Shaw, who's an HR executive, as well as a PhD in organizational psychology. So welcome, both of you. Looking forward. This is a very, very prominent topic right now. Within our affiliate network, we're certainly dealing with pain patients. We've had several instances that have occurred, and we thought it would be a great topic to discuss and share with others in the space. So, Dr. Hatchis, I'm going to start with you. Can you give just a couple examples of a real life situation that you've had, and then kind of what the red flags were, and then how you handled that situation?
Sure. So I've had so many that I really had to narrow down a couple of examples here and go off of that. So when I was practicing out in Arizona, there was one patient who basically came in with the expectation that she was going to obtain a large amount of narcotic prescription medications. That was her goal, and that was what was going to happen in her mind to obtain this, and nothing else was going to stop her. So, with that preface, I'll continue. I typically get records of my patients prior to going in and physically seeing them for the visit. So in Arizona, I had the prescription drug monitoring program records printed. I had all the new patient paperwork previously done where I was able to see it. And I was able to piece together everything to know that this person was absolutely going to be, an issue or a problem. So what I did was in an attempt to de-escalate the situation to a degree, I had my medical assistant go in and basically tell the patient what type of practice this is, meaning that this is not a high opioid practice or a practice that just prescribes opioid medications without other sorts of interventions being involved, whether that's therapy, whether that's interventional pain management injections, so forth and so on. And she was ballistic at that point because I think she kind of smelled what was cooking. So I didn't even have an opportunity to go in and see the patient. She started yelling, screaming, causing a whole ruckus in the office, making other patients in the practice, become very anxious. And it was to the point where we had multiple people from her staff try to calm her down. And I wound up not even seeing the patient as a patient because it got so crazy that I told my staff, I said, if this is how this person is acting, there's absolutely no way I want to take on this person to, even have a discussion on this because it was beyond control. So we had to call the police. Police were called. There were either 2 or 3 officers that came. She was not taking it. She basically, long story short, got arrested. She was taken in, and I thought that that would be the last of it. Well, fast forward 2 or 3 months later, I get a letter from the board saying that they're inquiring about this situation. And the patient wrote this whole not mentally stable letter to the board. And once we wrote our letter back to retort, a few days later, they wrote us back saying, "Never mind, we're all good." But it came to this point where you have some patients just, if they're not getting their way, they think that this is, Burger King where they could have it their way, and they're going into a situation where they could just order off the menu and there's no other, thought process or consequences behind it. And this is something that unfortunately, in the United States of America, it's a huge problem of entitlement, like we were discussing before. So it's something that unfortunately, this patient really was just beyond any sort of intervention. They came in with a mission, and nothing was steering them clear of this mission. So it's a sad situation. I wish we could have actually got to the point where the patient was amenable to having a true discussion and being able to help them out. But it was very clear that that was not what was on the agenda for that day. So that was probably the one of the more animated encounters this way. And then there's been plenty of others where, patients would come in and they were expecting maybe a medication. I would say, well, hold on, I don't think that's the best idea, or I think we're a little bit too high right now with the medications, or it's too frequent, but I have a solution, meaning we could either do injections or we could do other types of adjuvant medications that would also help to reduce this person's pain, right? So there's plenty of ways of doing it for de-escalation, but I at least wanted to give that one example, and I could give another at some other point, but I feel like I've blathered on a little bit too much about this one, so
No,
I'll
no,
hand it back to you.
very, very, very interesting. So one of the takeaways that I get from what you're saying is preparation and being proactive is something that's kind of key also, right? You looked into and you anticipated that this could happen based on looking at the chart, finding out the patient's history to some extent. Is there anything, I'm curious, is there anything like in the physical setting of the office that you guys are aware of, or when you have a potential situation, how the rooms are set up or the office? Do you have any insights on that?
Sure. So I know where we're currently practicing, we try to leave the door at least cracked open. And I as a precaution, I don't go into a room alone ever, unless I am family members with the patient or very good friends or really know the patient personally, to where I feel comfortable with that. So I'm always bringing along either a medical student, a medical resident, a scribe, a medical assistant, anybody that can at least corroborate, in my defense if something were to happen. So I think that's a very, poignant thing to mention, because plenty of times, it's the he said, she said line. And I mean, look, everybody's out to get physicians or medical professionals. It's an easy target. And there are not too many laws protecting physicians, nor we were talking about healthcare workers in general, how there's just such violent tendencies in the US, against healthcare workers for whatever reason. Doesn't make sense to me, but that is prolific within our society. So I'm fortunate that I do know martial arts very well. I do feel very, capable of protecting myself in that way as a relatively young male. But for those that are, female, or those that maybe don't know what I know, there needs to be an extra, caution there. And to have an extra person, I think, kind of will in itself deflate a lot of what could potentially have gone wrong if it's just you in the room.
Yeah, and sometimes, just the element of surprise or just the, not anticipating what's going to occur. As you know, Dr. Hadgis and Darla, a good portion of my career, in the beginning of my career, I was in behavioral health. I was a behavioral health clinician. And one of my psychologists in the office next to me was actually stabbed by a patient on her way to
Wow.
her car. So this, it's not something new. This was probably 25 years ago. But it does feel like there's some escalation in violence in healthcare. And we've seen some of these horror stories of providers being harmed, in some cases murdered. Those are some great real life stories. Darla, can you shed some insight, just kind of like on some statistics and some techniques that people can use to help in these uncomfortable and tense situations?
Yeah, absolutely. Well, I mean, like you were already talking about, this is very prolific within the healthcare industry. Not to get too deep in it, but Bureau of Labor Statistics, they track all sorts of workplace violence incidents. They show people in healthcare are 5 times more likely to be involved in some sort of incident within the workplace. And if you're a healthcare professional, more than 50% will experience either verbal or physical workplace violence within the course of their career. So it's more prolific in certain specialties, I would say, as well. ER doctors, pain, behavioral health. That's my background as well, Mike. So yeah, I've seen it a lot in the behavioral health and pain space and in the emergency room spaces. But as you said, it is something. It is a problem. And I think, what to Dr. Hatch's point is preparation is key. I love that you talked about how you set up your office, making sure you're not alone in the room. I mean, those things are so important, especially because the more people you have that can intervene to help someone who's starting to get anxious, the better chance you have of successfully de-escalating. I think the best way to really prepare yourself is to learn the signs. Like you talked about looking at a chart, right, to see their history. Sometimes there is no history. Sometimes you won't know until you get in a room with this person. And so it's important to just start recognizing, is this a situation where this person could go from 0 to 60? A lot of times it won't. Like, I think most of the time you can stop it before it gets too crazy. It'll go maybe to level 5, level 6 before it jumps to a level 10. You can stop it at that level 5, right? I like to use the Gaines mnemonic, right? So when they start doing wild gestures, they're clenching their fists, they're acting out stuff, like they're behaving in like kind of a suspicious or aggressive manner. Sometimes they'll ramble on and their reasoning skills won't sound congruent, right? You can tell that this person's not really making a lot of sense. If there's any noticeable signs, obviously, of being high or drunk or any of that. And then of course, just twitching, like you can see agitation. Humans, we are very, very socially conscious people. I always say, trust your gut, right? Like sometimes you'll just have someone who's behaving in a way that maybe they're not outwardly showing signs, but you've just got this gut feeling that something could be wrong here. You need to trust that. And always make sure when you have someone that you feel could get out of, go to that level of 10, that you make sure you have someone else in the room. Of course, once you have that situation, there's lots of techniques you can use to de-escalate depending on what it is. I think the most important thing is to be factual, but also to be empathetic, right? You never want to give in and reward that behavior. You definitely want to create firm boundaries, but you also at the same time want to empathize it, because a lot of people, they get really frustrated when they don't feel heard, right? So it's important to repeat back what they say. I call that mirroring. Okay, I hear you're frustrated because you can't get an appointment. I'm sorry to hear that. How can I help you resolve this, right? They need to feel heard. They need to feel empathized with. Though that's a really great de-escalation technique. Speaking calmly, you should never shout back. As their voice raises, your voice should get softer, and that just subconsciously helps people to calm down. Asking open-ended questions, allowing them to vent a little bit. I always say try and remove them from any place where there could be, I don't know, a stapler. I literally had a patient throw a stapler at a nurse once because she just picked it up off of a
Wow.
desk, put it at her head. So, like trying to be aware of what in the room could be used as a weapon if it happened. So as I said, just kind of try and isolate if there's barriers. I don't know, some of the offices I worked in, they actually have like a partition between the receptionist desk and the patient, to kind of protect the people behind the desk a little bit. So any type of furniture you can use as a barrier, standing behind a chair. You want to make sure that there's separation and you're not getting in each other's personal space. So, I mean, these are just some things you can do. Obviously, if you cannot de-escalate that situation, you do need to try and, do what Dr. Hatches did, which is call the police, get help. I would also recommend having code words. So a lot of times when you're in a situation with a patient, and you can see that they're not calming down, you've tried to empathize, you've tried to help them, they're not rational, they're getting more and more agitated, and you feel it could get violent, you should have a code word that you have, or some sort of communication that you can give to someone within the vicinity without alerting them that we're calling the cops. And because that can just set them off even more.
That's a
So
great one.
yeah, it's really important, though, I think more than anything, to actually prepare and train to these things within an office. Have a role play, have a situation where you have someone play an outraged patient, how practice the de-escalation, because you don't want to be practicing it the first time that you actually have to deal with it. You want to practice these ahead of time. So if I give anyone any advice, it's have drills, right? Have these drills where you are actually discussing how do we de-escalate and what are our code words and what do we do if we feel safety is a problem. So
Some great insights, Darla. That's really helpful. Dr. Hatches, I'm wondering if you have like an example of another real life example. The first one was great, but another example of, where you were in that situation and what was successfully done with you or your staff to calm a situation that felt like it could potentially get out of control.
I don't have any as animated as that my last example, but there's quite a few times where I will say that patients come in and they are gung-ho to get a refill of their medicine. They have the medicine containers out already. They're displayed on the table. It's like, you're going in there and you're thinking that you're going to be buying something with, what they have there, and they have the paperwork and the notes and everything. And it's like they're making you a presentation. You feel like you're on Shark Tank with Mark Cuban, and you're going to invest, right? So you walk in there and you're like, oh, okay, I guess, we're trying to do some business here, right? And I've seen this so many times, I already know how to approach the subject. So typically what I'll do is I'll say, okay, I think there's two parts of this discussion, right? We're going to talk about your medications, but that's secondary to me. I want to know more about you first. I need to know why you're actually here, what we're treating, and kind of get into really what it is, and is this even appropriate to be dealing with these types of meds, number one, right? So I'll kind of get them first and say, okay, oh, you have lower back pain. Oh, you have neck pain. Oh, what is this? What have you had done? Have you had therapy? Have you had injections? Have you done, all the stuff that we typically ask? Do the physical exam, let them know what the assessment is, let them know what my plan is in terms of imaging or procedures or whatever else it might be. And then I say, okay, now we're going to have the discussion on these meds. Let's check the prescription drug monitoring program again. Let's check all the other, opioid risk tool. Let's check all this other stuff that we do, piece everything together with the examination, with the history, with the assessment, and what our plan would be, and then determine if all this is appropriate, right? And very often it will be appropriate. Maybe they're just taking a low level of, medications at this point, and they haven't had, treatment. And we could say, what, we could keep you afloat on this for a while, but just know that our goal is to eventually get you off of all this, right? Or it might be that they're on so much that you're like, look, there's no way I could do this. I could start bringing you down off of this medicine, but there's no way from the outset, I'm going to tell you right now that I'm comfortable with this, and this is not in your best interest, and explain to them, all the different things that, opioids are not great for you long term, and especially if that's combined with benzodiazepines or barbiturates or other psychiatric medications, or known history of obstructive sleep apnea, or whatever it might be, kind of in that general context. There needs to be a discussion on that. So I would say probably 7, 8 out of 10 times, once I go through that with the patient, they're in agreement and they say, what, that makes sense. Thank you for that explanation. Nobody's ever sat down with me and kind of explained this to me or discussed it with me. And thank you for providing me with other options. I really just want my pain to go away. 75% of the time, that's all that there is. And then, they're a patient of yours for life at that point, if they truly believe that. And really, that's the patient that you want in your practice. The other 20-25% of the time, those are the patients you don't want in your practice, right? Those are the ones that, just want their pills. They're not amenable to, getting anything other than the medication that they were set out to get. They're going to be the patients most likely that are not going to get their imaging studies done on time. They're not going to show up for any procedures that you might order, but they're going to show up 10 minutes early for all their medication refills, right? So, and again, this is not a steadfast rule, but this is more of a, what happens a majority of the time. So I really try to set the intention on the very first visit with the patient and let them know this is Dr. Jesse Hatchis and this is Dr. Jesse Hatchis's practice. And, what are you to be, expected on day one? And those expectations are going to be carried, through on visits 2, 3, 4, and so on.
The two main takeaways that I have, one would be communication, having good communication skills with your patients. The secondly, it sounds like the majority of the instances revolve around medications. Is that what you see? Does it have to do with the medication management?
I would say 95% of the time it's medication management, and the other 5 to 10% of the time, it's issues with scheduling or something revolving around the office staff. Those are relatively easy to control. You could say, oh, you know what, I'm going to, speak with, our manager. They're going to get you set up, or right out here, we're going to get you rescheduled. Apologize for the confusion. It's usually like a 1 or 2 sentence thing. Sometimes you get an irate patient who is not taking no for an answer. And, you kind of have to tell them that, look, you're talking to me as a medical provider who's here to treat you medically. The stuff that you're talking about is not medical. It's scheduling, or it's billing, or it's some other department. There's very little that I could personally do to help you with this. But what I can do is set you up with the appropriate person to help you with that. And I said, if you want to spend your time, my limited time with our visit today discussing this, that's fine. But that's going to limit us from actually, talking about the stuff that I want to talk to you about, which is treating you, which is why you're really here.
That's a great point. Just is getting patients to focus, getting the patient to focus on the big picture. A lot of times I've seen the escalation happens when they're allowed to go off on tangents, and you kind of have to redirect their focus of, I can help you with this. You're going to have to go over here to get help with this, right? And then allowing them, distracting them and redirecting their attention back to what you can help them with, giving them that sense of control of, you can go here for this, but I can help you with this. And that reiterates, I think, a lot of what we've talked about is that communication piece that you were talking about, Mike.
That's great. Darla, any final thoughts as we wrap up?
I would just say that these techniques are not just usable in a patient-doctor situation, right? You will use these, in any situation where you've got someone who is irate and upset. The ability to, I think, calm people down and to get through the anger to being able to actually communicate is a life skill that I think everyone needs to cultivate, because it will help you no matter what situation you're in. Great.
Dr. Hatchis, any final thoughts?
Yeah, I was gonna say it's honestly very similar to like Chris Voss or like a terrorist negotiator, by utilizing all this, and not to liken patients to the T word or whatnot, but there are similarities in terms of somebody wanting to get something within this sort of negotiation, right? And you really need to be skilled in that, to not bend to destroy your own beliefs and principles, because that could lead to board issues, or that could lead to patient deaths if you choose the wrong adventure, so to speak, within that. So it is very important that you are the captain of the ship when it comes to the patient care, because ultimately what's decided upon could affect you and your career as well. So I think I would leave it at that.
Thank you. Some very, very good insights. And I want to thank you both for joining us. We have a whole library of additional videos and great topics. This was certainly a very relevant topic. To learn more about DxTx Pain and Spine, go to www.dxtxpas.com. Thank you.